Hello, I hope you're all well. I'm quite excited today. I talk about new insights into canine epilepsy management. I will touch on a couple of drug management, but also talk about some new, very exciting nutritional work we have been doing and how that can help to manage those epileptic patients. But more importantly, what you will learn today is you will learn today what epilepsy has to do with spaghetti. And so hang in there. At one stage, you will exactly know what I'm talking about and a lot more later on. What I wanted to do before we start, I wanted to actually tell you a little story about my own life. I had a dog called Beauty, and this is Beauty. Beauty was obviously beautiful. I got her as a rescue dog. She's an Irish setter, and she was 4 years of age when I got her as a rescue. And at that time, I was a vet student in France, and suddenly she developed seizures. And she had her first generalized tonic-clonic seizure in the house, and I was so panicked. I ran to the car, got a stethoscope, and listened to her chest. And guess what? I could not stop her seizure. But what it showed me is, and I hope you have probably had the same experience with owners, is it's a really difficult disease sometimes and quite frustrating because the seizures can happen anytime, anywhere, wherever you are. And they feel unpredictable, and you feel a little bit out of control. So one of the things to do is to help owners to get control back. And we'll talk about this a little bit later. And I'm sure you all realize that you cannot stop a seizure with your stethoscope, but I had to do something. So that's the case. The other thing is, what was quite remarkable is that people think that, and we know that epilepsy can have an impact in your life expectancy. And we know that dogs with epilepsy can be euthanized earlier than their peers. And there's some very good research from Denmark, from Mette Berend's group, who has shown this. But if you manage it correctly and look at the patient in a more holistic way or do multimodal treatment, I think you can actually go a long way. And Beauty was, at the end, 17 years of age. And I truly hope you think the same. It is quite a remarkable age for an Irish setter. So there's a lot of similarities, so I'll talk to you. This is now my recent dog. She's now also getting a little bit older, and we both are icing or graying as we speak. But saying that, there's a lot of similarities between the species. There's a lot of knowledge we know from human medicine, and I think that's one of the most fascinating things, is that human medicine has informed us, and we can take the human patient to develop new treatments, and vice versa. We know that epilepsy in dogs can also benefit the human counterpart, and we definitely learn a lot, and you will learn a bit more about this when we go through the talk today. One of the very interesting things we have been doing is we are looking more at various aspects of how epilepsy and seizure activity can influence people's life. And one study, and this is really some very fresh data I'm showing you here, is we ask owners to take saliva cortisol levels. So we asked them to take, obviously, saliva, and we measured the cortisol, and asked them to do the same at the same time for themselves, and then did this 20 minutes after the seizure has stopped, and also 40 minutes, and then we did time match controls on a day where there was no seizure activity. And no surprise, but still very interesting, is that obviously having a seizure did increase the cortisol levels in the saliva of the dog, but also in people. Interestingly, the cortisol levels in the dog were longer higher than in people. So people really do have a little stressful moment, and we'll talk about this, how we can help the patient and at the same time the owner as well to cope with those seizure activities. One of the very interesting and one of the penny drop moments I had in my life was last year we launched an epilepsy app, one of the ways of how to give owners a bit more control back, making actually them a partner in the management of the epileptic patient. And when we launched the epilepsy app, I had a human with epilepsy, a person with epilepsy, speak and tell us about her experiences. And that was absolutely fascinating. And the reason why it was absolutely fascinating, I had actually tears in my eyes at the end of her presentation, is because I understood a lot more what we are also doing to our patient. And what she was explaining was that she started to have epilepsy when she was 14 years of age, and now she was 38 years of age and stopped having seizures. And the way she got to control her seizure was by having this one neurology consultant who helped her develop a multimodal and holistic approach of how to handle and treat her epilepsy. And it ain't just drugs. So it was not just the drugs. And actually one of the things which was really, like I said, a penny drop moment for me is that she totally appreciated that one has to control the seizures and drugs are important. But she said, Holger, you know, one of the most things people and doctors forget is with the side effects, you live every day, every minute of your day, you're living with the side effects. But with the seizures, they happen a fortnight or every couple of months. And yes, they are horrible at that moment of time, but actually the side effects can be more challenging. So having a balance of looking at her personal circumstances, nutrition, making sure that she doesn't have any stress further, any trigger factors, plus a good drug which fits to her life and also didn't cause her too many side effects was very important for her. And I think that's something we sometimes forget in veterinary medicine because we give the drugs and don't really realize the impact side effects might have on that patient. And also something really interesting for me, and this is something we just don't experience obviously in pets as much, but she said, Holger, if I have a seizure down in London, I've been robbed, people have taken my smartphone away, they have looked and take my purse away, and one of the key moments is when I have a seizure at home. And the reason is, yes, in the seizure I'm unconscious, I don't know where I am, and that's all fine, but when you wake up, you are not aware really yet you're disorientated, you are stressed, you are worried, and having then someone who is from your family and who loves you is really important. And this is something it's a really easy fact to know, and that's something you can do for every owner, and telling them actually it makes a difference when they care for their pet and are there for them. And also I'm actually quite confident that would decrease those cortisol saliva levels significantly if we give the owners and make them part of our team. And we know this as a clinician, right? Animals are normal when they come into your vet practice because the disease process, the disease or the epilepsy, the fits are actually happening at home when you don't see them. So having this owner well educated and part of your treatment plan and part of the team for the care of that pet are essential. So we know that dogs with epilepsy have an increased risk of premature death, like we said. We also know that behavior changes are more likely. There is a bidirectional relationship between them, definitely documented in humans. People with depression are more likely to get epilepsy. People with epilepsy are more likely to get depression. We have done a study and found that dogs, drug-naive and drug-resistant epileptic pets do have some behavior changes, and we'll talk about this at the end of this presentation. We also know that it has an impact on their quality of life, and we do know that obviously if the quality of life of the owner is impacted, also the one for the pet is, and vice versa. We just recently published a study in a UK journal called The Vet Record, where we looked and did some multivariate statistical analysis and looked at the one factors which really was associated with quality of life impairments for owners. And when you looked at what the carer perceived, what impacts the dog's quality of life, it was a high seizure frequency. And again, there's no surprise. So we can imagine that if an animal has a high seizure frequency, that they would perceive the animal more potentially having an impact on their quality of life and receiving a third anti-epileptic drug, and that's also not a surprise, and we know that having that as well causes some more increased side effects. On the other hand side, when you looked at the owner's quality of life, there were two main factors which came up. It was the wobbliness, the ataxia, and also the sedation level, so having more sleepiness. And there's a bidirectional relationship, obviously, because we take the owner as a proxy. So if you have a decrease in quality of life of the pet, you will also have this from the owner and vice versa. So I hope you can see that slide. We look at epilepsy a lot more in a more complex way rather than just doing a complex simplicity. We used to look just at seizure control, but now we have an epilepsy clinic. I really take owners on board and speak with them of the quality of life of that beloved pet. And what plays a role in that is the environment, nutrition, the brain development and natural aging of a brain, the treatment we give in terms of side effects, and we already covered that. How good is the seizure control? Is it not idiopathic epilepsy? Obviously, if there's an underlying cause that could affect this quality of life, because there could be other neurological deficits, and some of the general epilepsy characteristics. And like I said before, we need to think also about epilepsy being a brain disease, which seizures is the most prominent clinical signs, but also there are some behavior factors we need to consider. So just for you, a short little break, think about it. How high would you think is the percentage of drug resistance in dogs with epilepsy? Is it 10 to 15%, 20 to 30%, 40 to 50%, or 50 to 60%? And I had a very good colleague of mine who unfortunately left us now, and went to Norway, and is one of the neurologists in Norway. And he always said, Holger, you know what we do with the students? They come to us, they are very book smart, and we make them street smart when we do the neurological rotation. And that's exactly what I hope we can achieve, because the next question is, how many of those dogs actually do you think come into seizure remission? So how many of them actually stop? And the first question you saw earlier, I'm sure that you all have some book knowledge, and you will think, oh, this is probably around a third. But how many actually stop seizuring? Because the number, the third, comes from a lot of studies where they have used 15% or more reduction of seizure frequency rather than seizure remission. And we'll talk about this in more details in a second. So, when you speak to any neurologist, and definitely if you speak to my residents, they think epilepsy is like the Titanic. It's just, you know, it just gets worse. The owners are coming back, and it's really a bad disease. And the reason is, and we'll talk about this in a bit more detail, don't forget that some of the key opinion leaders, they will see the worst of the worst cases. So most of the times, you in first opinion practice, in general practice, do an amazing job. And you are pre-selecting those individuals who are coming to us and are very difficult to control. So definitely we see quite a few dogs which are a challenge. And that's also has informed my decision-making process and has also helped me to look at new ways of how to manage epilepsy. And the other reason is there is this, I think, it's not a myth, but there's a hypothesis that every seizure backs another seizure. It comes from the phenomenon of kindling. So when you, for example, you can stimulate a brain, and you can stimulate a brain on a sub-threshold stimulus, and if you do this repeatedly, that brain will suddenly become epileptic, and at one stage even cause seizure activity. And because of that, because of this learning phenomenon, what people call the kindling phenomenon, people think that a seizure backs another seizure. The reality is, if you use some of the kindling models in rodents, you cannot really elicit epilepsy, because epilepsy is defined that an animal has, or a human has, spontaneous recurrent seizure activity. In those kindling models, you normally have to stimulate them with a stimulus again to get a seizure activity. So you don't really make them epileptic. However, we do know that there is a cohort of animals with a high seizure frequency and high seizure density, especially when they have cluster seizures, which can get worse. So there is a population of animals which do get worse. And the reason behind that is that probably there is a second mechanism which makes them less well respond to anti-epileptic drugs, and also is driving the disease forward. But if this theory would be true for all, then we would definitely not see I've seen patients which had very severe epilepsy and suddenly they stopped seizuring altogether. I've seen patients going first worse and then better again. I've seen also some very well-controlled ones where we stop medication and then they get worse. And so there's not one shoe-fits-all feet approach. And epilepsy is a very heterogeneous disease. It's normally chronic, and there are certain factors which can make it worse, but sometimes also goes into spontaneous remission, like the patient I explained to you earlier, the person. So when you look at the original definition of drug-resistant epilepsy, or at that stage pharmacoresistant epilepsy, people said if you had 2 antiepileptic drugs on board and they both were in a therapeutic serum concentration and you did not have a seizure frequency reduction by more than 50% or equal 50%, then the animal or the human would be classified as drug-resistant. Saying that, people realized that, as you also saw earlier, that perhaps still having seizures is not the ideal thing. Yes, you can show that you increase more than by chance that the patient will stop seizuring because you make it more than 50%, saying that it might be quite influential when you do drug development, but might not be so good for the patient and their quality of life. So there was a special task force from the International League Against Epilepsy, and what they did is they said, actually what we want to achieve, because we have shown this has the best effect on quality of life, is freedom of seizures, and at the same time we have to look at side effect levels, and that's something we need to take forward when we are looking at new treatment options, and so that's an important fact to remember. We talk a little bit about the International Veterinary Epilepsy Task Force later, but we took a very similar approach, more than 25 specialists and general practitioners working together on talking what actually defining how does success look like. And what we said is we also want in veterinary medicine take the goal that we want to cure epilepsy or at least have a cessation of the seizure activity. And how do we know that we get there? If you have a 3 times longest pre-treatment interval, and it has to be at least 3 months of seizure freedom. That means if you have a patient which has 1 seizure every month, and then you are starting a treatment and they don't have seizure for at least 3 and a bit more months, then it would be at that time a treatment success. Saying that, we totally appreciate that there's a high proportion of dogs which will not stop seizuring, and so we also had a partial therapeutic success, which is very much down the line of the reduction more than 50%. We do know that there are some clinical factors which make it more likely that a patient might need more aggressive treatment and also might not respond as easily. Especially high seizure frequency, cluster seizures, or high seizure density, prolonged seizure activity, and the number of antiepileptic drugs you have tried before. Every time you try another antiepileptic drug, you are going down with the likelihood of that patient responding to the medication. We also know that there is a relationship that intact male and female dogs have a higher likelihood of cluster seizures, but they are not always related to the being intact to drug resistance. But we talk about male dogs in a second in more detail. We did a study in our epilepsy clinic. We followed patients for quite a long time and wanted to see which of those will develop drug-resistant epilepsy, and we defined it at that time less of 50% reduction in seizure frequency. And there were 2 main things when we looked at it. In the cohort, we found that male dogs were actually more likely to be drug resistant, and that's also to be known that male dogs have anyway a higher tendency to have epilepsy, and cluster seizures was one of the factors which came out. And as more we looked into it, it became very apparent that as closer those seizures are together, as more likely this animal will not respond to medication. It was not at the age of presentation, time until diagnosis, or how long an antiepileptic was given, or even the number of seizures before, because when you did the multivariate statistic analysis, that all get out, it was about the seizure density. So obviously, if you have a lot of seizures, you will also have an increased number of seizures in total, but when you look at the one factors which makes a difference, it's normally seizure density or cluster seizures, and status epilepticus was close to be also significant, and very young dogs also were less likely to respond. We also found, now this is an English study, so Border Collie German Shepherds were high on the list, and Staffordshire Bull Terriers, because these are the dogs which come in and have cluster seizures, so there was no surprise here. So, talking about drug-resistant epilepsy, and I'm sorry I've talked about so much, but I did my PhD in that, so I always kind of, and we deal with this on a daily level, and you can, if you go to any conference, you will always hear neurologists talk about what else can we do without drug-resistant, because that's our daily life, right? It's our daily bread, what we do every day. And we have seen and looked at different reasons why that might be, and one of the areas I got really interested in is about the environment and the diet, and especially thinking also about the human patients. However, for most practitioners, epilepsy is actually not such a horrific disease. It can be quite a good sailing, and there's an emotional loading to it, so you might remember those patients which had a more severe epilepsy phenotype, but most of them are chronic. They will have a seizure here or there, and they are, if you do it well, can be easily controlled. Is there a magic wand in epilepsy treatment? And we'll talk about this in detail throughout the talk. So when you look at human medicine and the development of anti-epileptic drugs, and there's now even a fourth generation, you can see that there has been quite a few number of drugs being developed. And if you compare, however, the efficacy of phenobarb versus third or fourth generation anti-epileptic drugs, there ain't so much difference. They still have what I call the magic 2/3, 1/3 rule. You still have 1/3 of the patients which will not respond to your drugs. However, the big difference between a third generation drug, for example, like levetiracetam and phenobarb, is the side effect profile. And so they have improved over time because they have realized that in the human market, that obviously side effects are important, and people need to take this into account, and that also the compliance go down. So if you obviously have a patient on phenobarb, it might be that they don't want to continue with the phenobarb and then stop the medication, which would be detrimental for the seizure control. How does it look in dogs? And I just highlighted you some drugs we have been using successfully in epileptic patients, and there is also a drug you might not be familiar in the US. It's called imipitoin or Paxion. It's a drug which has been solely developed for the veterinary market, and it's available now in multiple countries, including the EU. And like with the other drugs, has potentially less side effects. So this follows this trend of a third generation drug. But the mainstay still is phenobarbital bromide, and then I talk a bit more about the different drugs and when to use them and how in a second. So in human medicine, around a third of the patients will be drug resistant, and most of them, drug resistant patients, will have temporal lobe epilepsy and have some changes in the temporal lobe. How does it look in dogs? And this is where it becomes a little bit challenging, because most of the data comes from referral hospital population, and if you come to my clinic, it's very unlikely that you stop having seizures, meaning that the dogs don't stop seizuring, and it's only 14% of the dogs we will see will become seizure-free. So, and this is quite similar to what other people have reported in referral settings, that 75 to 85% will continue having seizures, and 20 to 30% of them will need multiple drugs. If you think, I mean, this is obviously not US, this is the Great Britain. We did a study in first opinion practice, so we have a big database of first opinion practices, and we estimated idiopathic epilepsy to be around 0.6 in prevalence. You have around 9.4 million dogs in the UK. That means you have a small town of 55,000 dogs with epilepsy, and then you can see obviously 44,000 will continue seizuring, and 10,000 taking the figures which I mentioned before. And like I said before, there's this magic 1/3, 2/3 rule. So if you come to us, then there will be actually the majority, because we see a very severe phenotype, will not respond to treatment. A very, very good and interesting study from Texas and Cornell came out, and what they did there is they compared first-line phenobarb with potassium bromide as a monotherapy, and what they found is a remarkable, actually, number of dogs became seizure-free in the 6 months trial period. So 85% with phenobarb and 52% with bromide, and which shows you that the referral hospital population might be different than the first opinion one. So actually, for you guys, it will be a lot easier to treat than for most specialist practices. The other thing is, idiopathic epilepsy just means that you have ruled out a lot of other diseases. It's not one disease. It could be still have multiple reasons why you have a patient with epilepsy. It could be that gene defect, this receptor could be altered, or that transporter, or a combination of that. So there's multiple reasons. The only thing what you've done is you excluded most of the structural metabolic reasons for that. So it's idiopathic epilepsy. Even if you don't know what it is, it could be still multiple different brain diseases hiding behind that title. So some of them will respond, and some of them might not respond to the medication we have at the moment. And this is highlighted by Simon Shorborn, who also was part of the epilepsy task force, and he did a really nice one. He's actually saying it's not always easy to define what causes the disease itself. And as always, people in the past, they just by thinking, were probably smarter than what we do nowadays, and they come up with this watershed theory. So if you think about a riverbed, and you have a lot of arms of waters coming together, then obviously at one stage there might be water just too much, and you will have them going over the borders of the river, and you will have a flood. And the same happens with epilepsy. So if you take this approach and you think about that, then it's probably wrong just to say, okay, we give one drug and that will fix it all, and the patient will never come back to the clinic and have seizure activity anymore. So we really are working, and especially probably driven by our first opinion practitioners being so excellent in managing this condition already, by looking at a multimodal or holistic approach. So we look at how can we help owners to remove any potential triggers, stress factors might be important, anti-epileptic drug, nutrition, and if you take all this together, then you might have a better epilepsy control. So what do we treat when we treat epilepsy is something also we should not forget. This is a really nice scheme highlighting this. It also tells you that you could have multiple hit factors. We often speak about a second hit model. So you could have, for example, a gene defect, and then there's another event, and then suddenly you might develop epileptogenesis, a development of epilepsy, or the brain will heal itself and you won't see that, right? So the development of epileptogenesis could be treated by anti-epileptogenic treatments, and at the moment, there's no surprise here. There is actually not really any drug which fulfills this. There are some studies now coming out that with head trauma patient and pulse therapy of levetiracetam, you can potentially reduce the risk of the patient later on developing epilepsy. But otherwise, not really working so well. And we did a study with levetiracetam in a status epilepticus model, and we couldn't find that levetiracetam stopped that. So there is some anecdotal evidence, and we'll have to see. But at the moment, what we are doing, we are not treating against the degeneration of epilepsy. We are mainly only treating on the anticonvulsant. We are treating those spontaneous recurrent seizures. We are changing the threshold to make it less likely to fire. We are also not really disease modifying or are able to reverse the pharmacoresistant, drug-resistant phenotype. And don't forget that also behavior might be important, and we might need to think about this in a bit closer. We also know that epilepsy and the seizure frequency can fluctuate over time. Normally, owners come to you when the animal is at its worst, and then it can go what is called a regression to the mean, improve by itself again. So what I would like to mention to you, just as a little break, because I already gave you a lot of information, is we'll talk about the International Veterinary Epilepsy Task Force. Like I said before, we had specialists from all around the globe and from different areas of life. We had general practitioners involved, and to come up with a common language. And there's a lot of publications out there which are freely downloadable from BMC Vet and Research, and you might find interesting. We came up with a criteria for diagnosis of idiopathic epilepsy and came with a three-tier system of confidence. And the first one is actually, if you have an animal between 6 months and 6 years, a normal inter-ictal neuro exam, normal blood, normal urine, you have a very high chance it has idiopathic epilepsy. One study even saying 97% of the patients had idiopathic epilepsy. So it's a really good one to keep in the memory, and as a normal practitioner should be normally sufficient. However, if you do a Tier 2 diagnosis, then you need an MRI scan and CSF tap. If you do a Tier 3 diagnosis and confidence level, then you need also an EEG. So Tier 1 diagnosis can be done by anyone. At the same time, ACVM also did a consensus a panel, this time just about treatment. And what I wanted to do is just to give you a couple of key highlights about that. A lot of this work was driven by a systematic review we did, where we showed and looked at all the data out there, all the studies that have been published, and found that phenobarbital and imipitoin has the highest level of evidence out there for treatment effect, then followed by potassium bromide, then levetiracetam, and then zonisamide. We also looked at the tolerability level and the side effect level and the safety level, and found that levetiracetam is the safest, followed by imipitoin, Paxion, phenobarb, and potassium bromide. Then when to start treatment, actually both groups kind of agreed with each other that if you have an animal with status epilepticus or cluster seizures, severe post-ictal signs, a structural lesion is identified, you have an increase in seizure frequency or severity, or have 2 or more isolated seizures within 6 months, and this is mainly driven by quality of life assessments from owners because that's what they still tolerate. You can obviously start earlier than that. That was when we said you definitely have to start treatment. Then we looked at where do we have the highest level of evidence, and also looked at the level of tolerability, and we came up that phenobarbital imipitoin is drug number 1 for monotherapy, followed by bromide, and then levetiracetam and primidone. EVTF, so International Veterinary Epilepsy Task Force, came up with a very similar, start with phenobarb or imipitoin, and then potassium bromide as an add-on. We are a little bit more regulated in the European Union, and that's also what the legislation gives us, but it follows what also the specialists recommend. The other thing is it's all about giving control back to the owners. We developed an epilepsy app where people can be reminded when they have to give medication, and it looks like that compliance is not very good. Very preliminary data has shown that every second person will sometimes miss treatment in their pets, so it's really important that they keep a record of that and keep a record of the seizure activity and follow them over time, and then they can actually send you a PDF version of the epilepsy seizures activity over time to you with some standardized questionnaires. It's also really important, it's a very busy slide, and you find this all in the proposal, but really talking about epilepsy is important. And client education, we did a study just recently where we asked owners what they think is the most important, and client education came as number 1. So it's really important that you educate those owners when to give treatment, what to do, when to come back for blood tests, how much cost, what are the drug interactions, how is the diet. So it's a very busy slide. I apologize for this, but you can read it all at the Epilepsy Task Force. So, let's talk a little bit about spaghetti. So I'm sure every one of you has cooked spaghetti. I hope so, at least. And all of you know that at a certain time the water will boil. So the big question to ask is, will your water boil quicker or less quick when you add salt in? And that's actually not an easy question to answer, because it depends really how much salt you put in. But I think we all agree that depending how much salt you put in, you can change the time it takes for the water to boil. So you're changing the propensity of the water off the brain by adding certain substances and make it less likely to seizure, right? And the same is happening in the brain. When we give those anticonvulsant drugs, we just make it less likely to seizure. And we can actually do this with multiple treatment options. And very simple, and I won't go into detail too much, but just highlighting it, you can either increase your inhibition, or to get this balancing back the yin-yang of your brain and make it less likely for the brain to have seizure activity, or you block too much excitation, right? And this is how you can actually explain most anti-epileptic drugs. However, at the moment, most of the drugs we use are just on the inhibitory, and that's why we see all those side effects about sedation, ataxia, and sleepiness, and so on. We don't really have a lot of treatment options for the reduction of the excitatory pathway, and especially the ones which are working in humans don't really work in dogs, and the pharmacokinetics is not as good. So, when we talked to you earlier about it, there's a lot of drugs on the market, and the main change has been this side effect profile. So what's about diets, right? Because to be very honest, before I started on this journey, I was often asked by owners, what about the diet? So you give this, I'm sure, you have spoken to a lot of owners, and I give a lot of talks to breed clubs, and they all know that there's this magic diet, and I thought like, yeah. But actually, when you think about it, there might be something behind that. So what I would like to talk to you is about some general dietary considerations, and then we talk about some specialist nutrition, and I'm also talking then about the trial we have been doing. So when we talk about spaghetti, right, with the salt, there was obviously a reason why I spoke about this, because potassium bromide is a salt as well. And potassium bromide is commonly used as a second-line anti-epileptic drug, as we discussed earlier, and sometimes even as a monotherapy. And people add it to the diet, right? And we know that it is a salt, right? And actually, the body confuses potassium bromide with sodium chloride. So the bromide ions are confused with chloride ions, and you see that on the biochemistry results even. So it's not only the body, it's also the biochemistry analyzers, right? That you get this pseudo-hyperchloremia. And that also explains you the half-life, right? Because we recycle a lot of chloride on a daily level, and the same happens with bromide. So the clearance is really low. So if you have, for example, suddenly a high dietary intake in salt, your bromide levels in the epileptic dog will change. And I'm sure you have heard this before, but when you live on the seaside, or if, especially if you have dog owners which are normally living more in the inside of the continent, and then they go on vacation and they give, the dog is epileptic, they give potassium bromide, and the dog suddenly drinks a lot of salt waters, and it doesn't only have increased vomiting and diarrhea potentially, but also will have a higher clearance of the bromide ions because you have more chloride intake. So you really need to have a constant diet. And if I learned something even in our diet trial, is having a diet which is constant is really important, because I was not aware how much people feed their dogs. And we show our love by giving dogs food, right? And if you have a dog on phenobarb, for example, it makes you, on potassium bromide, it makes you more polyphagic. And by sharing your love, you give them food. And I definitely learned something by doing this diet trial, that how much people actually feed them garbage, to be honest. And already that might have an effect on improving seizure control. So there is a lot of been talk, and that was one of the things what breeder told me, that it could be an allergy, and there's actually not so much evidence out there, so only some anecdotal evidence there. There's some work been done in humans where epileptic patient might have had a higher trigger point, they have more allergic diseases, but the evidence is not very strong. There was a very kind of a non-controlled study done, but still a pilot study and still some data where dogs which had some gastrointestinal irritations were giving a hypoallergenic diet, and it apparently improved in those patients the seizure control. But that's all that has been done. Fatty acid supplementation is the other one, so omega-3 fatty acids has been discussed. There was a case report which was miraculously curing the epilepsy in that dog, but then there was a really nicely done study, which I mentioned in a second, where there was no effect, and there was an idea that omega-3 fatty acids, they can have potentially some anticonvulsant properties. They might work on the sodium channels and change the metabolism of the brain in general. And one of the big things at the moment, especially in drug-resistant epilepsy, is about inflammation driving that drug resistance. So that's why people have definitely recommended this. And in people, there's really conflicting evidence, and it really depends a little bit on low-dose fish oil might have had a better effect than high dose. So it really is a dosing effect, and I think we don't know as much yet in dogs what would be the right dose. And like I said earlier, there was a nice study done from Nicholas Granger, who is at Bristol University, and did this work when he was in Cambridge, where he did a very nice control study comparing olive oil with an omega-3 fatty acid supplementation, and they couldn't find a difference in seizure control. Ketogenic diet. That's one of the things which always comes up because it works relatively well in children. It's normally a very high-fat diet, a low-carb and low-protein. You're changing the brain metabolism, and that's one of the reasons why it might work. People feel in children this it's quite well tolerated. In adults, it's more difficult because the compliance goes down. People don't like to eat such a diet for a long time, and it's more difficult, but it has shown some remarkable results in children. There's 4 main theories behind it. They think, like I said before, you are changing your brain metabolism. You are not only reducing the carbohydrate load, you also are improving the mitochondrial function. You have potentially even inhibition of some metabolic pathways, and even more interesting, potentially on inhibition on these glutamatergic, so on the excitatory transmission. There was a study done quite a while back, which only published as an abstract at ACVM and also presented there from some fantastic colleagues, Nat Patterson and Karen Munyana did this study, and they used this classic ketogenic diet, a high-fat, low-carbohydrate diet, and couldn't really find an effect in dogs, but dogs are also more difficult to actually get into ketosis, so that's one of the challenges they had. So, totally different. I gave a talk at BSAVA, which is one of our major conferences in Europe, in the UK, and I was asked to speak about canine cognitive dysfunction. And very interestingly, I came across a recent paper which was just published then about using some medium-chain triglycerides. And that was really interesting because a colleague of mine, someone I collaborate with, Matthew Walker, down at Queen Square in London, he was doing some work with those medium-chain fatty acids, in this case in rodents, and found that some of them might have an effect. And that something is really interesting because valproate is a drug which is actually a medium-chain fatty acid, which also has been used for a very long time as an anti-epileptic drug, but has some side effects. But they found some certain other medium-chain fatty acids which might be actually quite beneficial. So what we did is we did a study together with Purina, and we wanted to test it in a very rigorous setup, and let me just walk you through that. So we wanted to have a medium-chain triglyceride diet, and it was really great to have Purina involved in the study to help us because we were completely blinded. It was a prospective, randomized, double-blinded, placebo-controlled crossover diet trial. We followed the dogs on each diet for a 3-month period, and they were randomized, like I said. So some started on a medium-chain triglyceride diet, some started on the placebo, and then after 3 months they swapped over. We wanted to have difficult-to-control patients, so they all had to be already treated chronically. They had to have at least one antiepileptic drug, and had to have 3 or more seizures in the last 3 months. So we wanted to have those patients which are difficult to control and which are one of the daily challenges of my life. And at the end, we had 21 dogs. Like I said earlier, you get more male dogs, and this is again replicated in this study. All of them had phenobarb on board. Most of them were also treated with potassium bromide, and 18 of them, and then some of them had also imipitoin, Depaxion, or levetiracetam. We had all different types of breed, but as you can see, it's quite common that you have in the drug-resistant groups are normally bigger dogs actually, and the mean was around 30 kilogram. The seizure frequency per month in the overall population decreased significantly, but actually more importantly and more interesting is, and these were really difficult to control epilepsy patients, 3 of them became completely seizure-free. We had 7 additional responders, so meaning an addition of those 3 dogs, which were seizure-free, had more than 50% reduction in seizure frequency, 5 had a reduction, and 6 had showed no results. As we wanted to eliminate the effect of cluster seizures, that means we have more than 1 seizure a day, we also looked at seizure day frequency, and also the seizure day frequency went down. So this is the day number of days where you had a seizure activity, 1 or multiple, and also that was significantly reduced. What we also wanted to see is how does it actually change over time. So wanted to look at the patients with a certain seizure frequency per month, and do we have a shift to a less severe phenotype. So as you can see on the top are the ones which had on the placebo diet, and they have a higher seizure frequency, so the individual dogs all come together here, and then when you put them on a diet, you actually have a shift to the left on having, in general, a lower seizure frequency. We also wanted to see how fast the effect is, right? Is it something which started very early on? And this is now showing you the day of the diet period and the total number of seizures in all of the dogs recorded on each day. And you can see that the effect was actually from the beginning. It really started straight away. You had a reduction, and it appeared to be quite similar over the 3-month period. So when we look at the overall results of this study, one of the important things is obviously it could have been all explained by giving a different type of diet could change your metabolism of your drugs. And we do know that phenobarb has an influence on your fat metabolism. So we wanted to see if actually the serum levels changed significantly, and there was no significant change between placebo and the MCT diet on phenobarb serum levels or potassium bromide levels. We didn't see also a difference in weight. We did get a significant increase in a ketone body, but we talk about this a little bit more because I don't think it's the main effect of that diet. So, as a summary and conclusion, what we could see that overall we got a reduction in seizure frequency, but more importantly, and as you know, you will not treat every patient will not respond. We had 71% of dogs showed a reduction, 48% of dogs showed more than 50% reduction, and then 48% of dogs achieved complete seizure freedom. And that was quite phenomenal, and those owners were really excited because they suddenly had a dog without seizure activity. More interestingly, also there was no increase in side effect profile and or in antiepileptic drug levels, and obviously we saw an increase in beta-hydroxybutyrate serum levels. Then just when we finished this study, this very exciting paper came out, again from Matthew Walker's group, where they shown that certain medium-chain triglycerides have actually a direct effect on this excitatory pathway. You might remember early on, I know I spoke to you a lot and I gave you quite a lot of information, that we don't really have any options to modulate the excitatory pathway. And it appears that some of those medium-chain triglycerides, especially some C10s, have a direct effect, a blocking effect on the AMPA receptor, so actually decreasing the excitatory pathway. So potentially what you're doing is you're not only improving the inhibitory pathway by the GABAergic drugs, but also decreasing the excitatory pathway, and that might give you the additional effect we have seen in these dogs. One other thing is, we talked earlier a little bit about that there are behavior changes, and we have seen that in patients with epilepsy. So we have seen that certain behaviors do alter. So we were also interested as a side study on if there's any changes or improvement in behaviors. And I have a postdoc, Yeni, just amazing postdoc. She has done amazing work. And she said, Holger, because I thought in the beginning that those dogs with epilepsy are more fearful. But when she put it all together, it actually looked more that they're more hyperactive. So they have more like ADHD-like behavior. And it looked that during the diet, certain of these factors, like chasing behavior, actually improved when they were on the MCT diet. Also, interestingly, some of the stranger-directed fear factors also improved when they were on the MCT diet. So not only the seizure-suppressing activity, but also improvement in the behavior. And that was not directly correlated, so it was not just the ones which had a significant improvement in seizure frequency reduction, had an improvement in the behavior profile. Like I said, it's a bit more complex, so some of them didn't have this seizure frequency reduction, but still had an improvement in behavior, and this is quite an interesting thing, and owners were quite happy about this. Just that you see that ADHD-type signs of the hyperactivity disorder is not something only our group has found. A really nice study in the Lagotto Romagnolo. They have a benign childhood epilepsy, so the seizure phenotype grows out of them, so they stop having seizures after a while. But when you follow them up over life, they also have more ADHD, so attention deficit hyperactivity disorder. And so that's something multiple groups are now finding, and it's just very fascinating. So I talked to you earlier about, I think we need to have a bit more holistic view when we look at treatment of epilepsy. It's not just one modality which would potentially help you. Is this now the diet, the magic wand? It's definitely not. It's one factor which needs to be considered, and in combination with all the other factors we talked about, it can definitely make a difference for quite a few patients. I spoke in Denmark before, and finding Wally is there actually finding Holger. And when you do those, when you have those individual patients who are very difficult to treat, then you need to find the one Holger, which actually the combination of drugs or treatments like nutrition type modalities or others, which will help you to help that patient. I hope you learned a little bit about epilepsy and what it has to do with spaghetti, and it leaves me in saying thank you to the whole team at the RVC, also to ProPlan Veterinary Diets Purina, especially Gary and Brian, who have been just amazing, and T-Law, my PhD student, who also helped with the study, and Rowena Packer. They have been all great. So thank you for listening, and speak to you and answer a couple of questions. So if you have any questions, I'm more than pleased to answer them. Oh, all right, there are some questions coming through. So the first question is, would you recommend feeding the medium-chain triglyceride diet alone without drugs? That's one of those rather challenging questions. It's very difficult to know this at this stage. I think what we have shown with the evidence we have, and also considering epilepsy, that there is an effect of the diet which improves the control when you have antiepileptic drugs on board. And I don't think that it's something we cannot answer at this stage. I think, as I explained earlier, I think we have to have a bit more multimodal approach, thinking about different factors, and I think diet is a very important one of that, and I've definitely been convinced, and I would actually thank all the owner and breeders who made me aware about over the years that I need to look into this, but I don't think it's the magic wand and you should just use MCT diets and everything will be fine. I think that's a bit too early to think this way, and perhaps never will be the right treatment, but it definitely is something we should consider. So the second question is, can you speak more about the mechanism of action of MCTs reducing seizure frequency? It definitely can. I think one of the very interesting factors is that when I started on this journey, I thought it's mainly because you change the brain metabolism, and that might be still one of the factors. We know that there might be some effects on mitochondrial function and so on, but I think the most exciting for me is that we finally might have something in veterinary medicine which is acting on those excitatory pathways. where we are actually reducing the increased excitation which you have in an epileptic brain and modulating this brain to make it more responsive to those drugs which work more in a GABAergic action. And I think that, again, together, that's definitely quite an interesting concept to think about, because you have a kind of a two-way approach rather than just going on one treatment plan where you just do the inhibitory or just the excitatory pathway, and actually this multimodal approach might be successful, and you might even be able to have use less drugs, because if you have a dog on a diet, and again that's something one would have to see in the long run, perhaps it doesn't need as much anti-epileptic drugs. And it's definitely a very good question to ask. And then there is another question. So the question is, what do you think is the next step in epilepsy management? That's a very good one, and it probably depends, because if everyone is now feeding the diet, I don't know what else I can recommend anymore. So I have to think about some new avenues. I think what we have definitely learned is that we have to understand the disease process a little bit better, the condition itself, what causes it, and identify different trigger factors. I think that what we see in people is that the management becomes a lot more individualized. So you might have first like a global approach, and then as soon a patient might not respond as well, then you have to have an arsenal of different options, which you then combine for that individual patient. And that's why I think it's so important to have this trust with the owners as well, and have a good working relationship, potentially having if you're in a first opinion practice, a good working relationship with your specialist, and really making it tailored to that patient, I think is probably the key, not only to get reduction in seizure frequency, which is often one of the main focus of veterinarians, but I think we need to learn to also consider side effect profiles, and we have done quite a bit. So we did, for example, a study recently where we looked at ataxia levels in dogs, and it's quite phenomenal that some treatments, they cause more ataxia than others. And I think if I think about something in the future, we need to become more dog focused and welfare focused and quality of life driven. And then it's not just about seizure management; it's also about making sure the quality of life is well cared for.